Central and branch retinal artery occlusions. Central retinal artery occlusion presents as sudden profound visual loss. Visual acuity is reduced to counting fingers or worse, and visual field is restricted to an island of vision in a temporal field. Ophthalmoscopy reveals pallid swelling of the retina, most obvious in the posterior segment, with a cherry red spot at the fovea. The retinal arteries are attenuated and boxcar segmentation of blood in the veins may be seen. Occasionally, emboli are seen in the central retinal artery or its branches. The retinal swelling subsides over a period of 4 to 6 weeks, leaving a relatively normal retinal appearance but a pale optic disc and attenuated arterioles. The patient is referred emergently to an ophthalmologist if seen within few hours after onset. Emergency treatment including laying the patient flat, ocular massage, high concentration of inhaled oxygen, intravenous acetazolamide, and anterior chamber paracentesis may influence the visual outcome. Thrombolysis, particularly by local intra-arterial injection but also intravenously, may improve overall outcome. The main management problem is identifying any intreatable underlying disorder. giant cell arteritis must be excluded in all older patients, especially because of the risk highest in the first few days of involvement of the other eye. If giant cell arteritis is suspected, one should institute high-dose corticosteroids immediately and proceed promptly to temporal artery biopsy. Carotid and cardiac sources of emboli must also be considered in retinal artery occlusion and appropriate treatment given to reduce the risk of stroke. Internal carotid artery dissection should be considered when central retinal artery occlusion is associated with head or neck pain. Branch retinal artery occlusion may also present with sudden loss of vision if the fovea is involved, but more commonly sudden loss of visual field is the presenting complaint. Fundal signs of retinal swelling and adjacent cotton wool spots are limited to the area of retina supplied by the occluded vessel. Embolic causes are proportionately more common than in central retinal artery occlusion. Migraine, oral contraceptives, and vasculitis must also be considered. Congenital or acquired thrombophilia has been identified in patients with central and branch retinal artery occlusions. Patients with branch retinal artery occlusions should be referred urgently to an ophthalmologist. Occlusion of the central vein, central retinal artery causes painless loss of vision in one eye with loss of light perception. It may have been preceded by episodes of transient blindness, that is amaurosis fugax, for 10 to 15 minutes. It is caused by an embolus, usually from the ipsilateral carotid artery. It is a medical emergency. Vision may be salvaged if occlusion occurred within 24 hours. Treatment consists of massaging the globe in an attempt to break up the embolus or get in to move distally. Inhalation of a mixture of 95% of oxygen and 5% of carbon dioxide to get the retinal vessels to dilate, and an IV infusion of acetazolamide to lower IOP, that is intraocular pressure. Position the patient in Trendelenburg position and monitor vital signs as detected. Offer reassurance and assist with additional testing and treatment is indicated. Thank you.